Thank you for having me. My father, a retired orthopedist, came to the Eastern Orthopedic Association for many, many years. I came first in 2006, and it's been a great organization. Thanks for having me. So I have several goals for this talk, but the first one is to maybe try to come up with one single thing that all of you luminaries don't already know, but I don't know if I'm going to succeed in that. They say that the fastest way to clear any conference room is to have a spine talk, and I think we've succeeded. It worked. Okay, so not coming up in this talk, but I think our biggest obstacle right now is insurance authorization, pre-certification. It's really unbelievable. I have a terrible myelopathic patient for tomorrow whose insurance company decided today that the surgery can't be done. So once we overcome that, we'll probably be in good shape. Is this my device to forward the slides? All right, wonderful. So, I don't have any disclosures for this talk at all. I've used many different arthroplasty implants over the years and have done some consulting work, but really nothing pertinent to this talk. Several issues to discuss today, and I think this is sort of reminiscent of our morning conferences where we go back and forth amongst our colleagues in neurosurgery and orthopedic surgery and debate sort of the merits or drawbacks of certain things we do, and a lot of these discussions and arguments go back many, many years, but still have pertinence today as we try to figure out the best solutions for patients. And I'll add in that obviously mastery in any of these techniques takes a lot of time, a lot of learning curve, and as certain things come into the marketplace and start to proliferate, it can be a little bit dangerous for people to employ them without mastery. So everything has a learning curve, and things like arthroplasty and laminoplasty require a lot of experience to do well and to do expertly for you young people out there. So for any of you who have children in the teens or 20s, or any of you who watch serial programs, your people watching Outer Banks are going to know that. Several scenes there from that show. That's Shem Creek right across the river, very beautiful. Go eat, go enjoy the water, it's spectacular. Dolphins are on call at all times. So intracervical discectomy and disc arthroplasty. It makes me think what my father used to tell me, that 90% of what he practiced in orthopedic practice, he really did not learn in residency. And a lot of things I didn't learn either. In his time, it was that hip arthroplasty, knee arthroplasty didn't exist. Arthroscopy hadn't yet been invented. Spine surgery was in its absolute infancy. Same for me. When I was training, disc arthroplasty was just beginning to come into utilization. It was brand new and very explosive and certainly had limits and drawbacks, but same with laminoplasty. So looking at the data retrospectively, I think it's pretty clear now that arthroplasty, certainly at 1 and 2 levels for well-indicated patients, is a completely reasonable alternative, and in some cases a superior alternative to ACDF. Different studies have shown a lower rate of adjacent segment disease. Almost all the randomized controlled trials have shown equivalent outcomes with patient-reported outcomes as well as overall success scores, and it may be a less well-reimbursed operation, but it also may be a more cost-effective operation. I don't tend to do 3 levels in my practice. Many of you may. I just find that a person who's got 3-level disease who needs surgery may be more of a chronic spondylotic myelopath in my hands. So there is some data certainly supporting that, but perhaps a bit less robust. And I think we'll learn a little bit more over time. Challenges remain. Obviously, with arthroplasty or ECDFs, dysphagia remains pretty consistent across the board, and I don't think we have any wonderful solutions to it. I used to use a NIMS tube in my practice very commonly, but I really don't anymore, as I think it's not a particularly effective tool, and I think too many false negatives can occur. But some people still use it. I think we need a better technology for that complication personally. Looking at other rates, heterotopic ossification still can happen commonly depending on technique. Osteolysis around implants can happen. Certainly subsidence can pose challenges. And implant failure, while it happens occasionally, is hopefully going less commonly. So ways to work around that, patient selection remains absolutely paramount. I think depending on your particular implant, accurate templating, knowing the size, the footprint, the lengths available is absolutely critical to avoid being in a bad position. In our population here in Charleston, we tend to have a bit older population with osteopenia, osteoporosis, and I think bone density is critical, and as well as the technique of decompression, a lot of surgeons who use the burr on ACDFs all the time and the end plates may run into increased rates of subsidence, so I would really try to carefully preserve the end plates at all times. And also you can see sometimes compromise of the decompression. So for you younger people, really you're there for the most part for radiculopathy, and a perfect decompression will always do well, sometimes regardless of the implant, but you really don't want to compromise your decompression, because the only thing harder than doing an arthroplasty perfectly well when you're a young surgeon is doing a revision when they still have radicular pain, which can be very difficult and tricky, and you really can't see anything on imaging very accurately. So I always do a pre-op CT scan, I'm sure all of you do, for various reasons, mainly to rule out facet arthropathy or reasons that will make your arthroplasty fail from same segment disease. And then, as Dr. Albert used to tell me all the time, Jamie, hope is not a strategy. So as these implants come into increased proliferation, and you do have to pursue revision strategies, being prepared for a corpectomy, being prepared to deal with implants that may have a large fin into the vertebral bodies, and having options available to you is exceptionally important. So this is a typical patient, multi-level disease, predominantly anteriorly, neutral or lordotic spine, anterior surgery, posterior surgery. We go back and forth in our conferences and with neurosurgeons very frequently. But obviously historical data showing relatively equivalent outcomes with what matters for these patients, myelopathy scoring, and long-term neurologic outcome. Apples and oranges, obviously, as far as complication rates, but I think that diminishes in time with experience. But obviously, if there's preoperative kyphosis, that would favor a more anterior approach for releases and correction, and just that individualized patient pathoanatomy approach recommended by Dr. Failings in that landmark article in 2013 is sort of how I approach things for each individual patient. So for posterior approaches, and the patient who is neutral, has got multi-level disease, potentially 4 levels, laminectomy and fusion advocates and laminoplasty advocates also may have equivalent outcomes, long-term neurological function, but laminoplasty is just an enormously effective tool that allows some degree of motion preservation and also has very, very good scores neurologically and long-term outcomes, but I do think has a bit of a learning curve that requires a lot of expertise for appropriate indications. Not appropriate for the kyphotic patient, and I think postoperative kyphosis, even in a patient who's got good cervical lordosis but has high kyphosis in the upper thoracic spine, can pose a challenge that can be one that can surprise you postoperatively. Complications, I think the C5 palsy rate is higher with fusion, but that may be certainly because we're correcting a lot more deformity in fusion cases in a lot of situations, trying to really create advanced lordosis with our surgical corrections. And post-op infection and posterior approaches, certainly vancomycin powder is absolutely critical. I use it all the time in appropriate patients, has helped decrease infection rates. Laminoplasty is still not as well reimbursed as fusion surgeries, and I think a lot of advocates would argue that that's not really appropriate, as that operation requires a lot of expertise, technique, time, and equivalent follow-up care. So as I mentioned, patients with upper thoracic kyphosis, I think, have been largely unappreciated historically as we focus more on cervical parameters regarding lordosis. And I've had a big revolution in this, and just as we've seen a huge revolution in lumbosacral spine surgery and reconstruction, appreciating sagittal balance and the pelvic incidence as being big keys to focus on with lumbar surgery, so are we looking at the T1 slope and the upper thoracic spine to guide us as far as what kind of lordosis to provide for patients in surgery and how we should really focus on this. So we spend a lot of time teaching our residents and hopefully future fellows the importance of this, because restoration of cervical lordosis is important, but being careful to avoid sagittal translation in the older patient with upper thoracic kyphosis is very, very important, and we focus on that. But calculating the T1 slope and using this equation, separating 16.5 from that will give you a guide as far as what cervical lordosis you would seek to achieve with regard to your operation that you choose. And then lastly, for me, neuromonitoring. I know in a lot of states it remains really the standard of care, but a recent poll from last year suggests most of us are still using monitoring, mostly for medical legal reasons and a bit less for pertinent clinical reasons. I think certainly in cervical spine surgery there are significant indications of patients with severe myelopathy or who require deformity correction, but I've just found I've used it less in practice. One funny anecdote is my previous anesthesiologist in upstate New York didn't really appreciate doing surgeries like this without paralysis. So for me, intraoperatively, we would have a lot of patient motion, and I found that using monitoring put the patient more at risk for neurologic injury because the anesthesia was so differently. But that's better now with different methods of anesthetics, but it's a very, very good, careful discussion with your anesthesia group how to do this well and safely. But most surgeons using it for medical legal reasons. I'm sure it can be a good active discussion between us, certainly for thoracolumbar deformity, pediatric scoliosis, et cetera. But I've just found myself using it a bit less over time. But thank you so much. Enjoy Charleston, and happy to enjoy any questions you might have.